Hi, my name is Chris Ferrand. I'm a licensed psychologist and I work for Christ Community Health Services and I work at our Fraser Clinic. Today I'm going to be talking with you about accessibility to mental health services, and we'll be orienting you to how the primary care behavioral health model places accessibility as a true north and a focal point for the work that we do. I have no conflicts of interest to report. So framing the problem, access in the US is increasingly becoming problematic. And there are multiple reasons for that. Um, we do have a shortage of providers or a maldistribution of providers where they're located. And there is also stigma about accessing care. And that tends to be pretty widespread, but even more prevalent in certain populations and in certain kind of cultural belief systems. Um, there is also the cost issue. Accessing care can be quite costly, and then there becomes the issue of whether or not insurance covers it or not, or whether or not you have to pay up front and submit a super bill. So cost is not always in our favor. And then there are also barriers to access, which I'll be covering at length as well. So at the same time, the need is growing. So during the pandemic, we have a huge rise in different mental health concerns, including substance use disorders, suicidal ideation, and a range of biopsychosocial concerns. And there tends to be a disproportionate effect in households with lower SES, and also a disproportionate effect on communities of color. And for many within our clinics, there will be language barriers. So making things even more difficult, a person has to try to communicate these very vulnerable matters um, with a provider, and they have to communicate through an interpreter. And that may be a phone interpreter, or it could be a video interpreter, or it could be a live interpreter. And and it could also be a virtual visit. So at its very worst, we might see a phone visit for a mental health problem where the patient is on the other end of the phone, but between you and the patient is an interpreter on the phone. So you really lose all of the kind of human connection. It really kind of diffuses that. And so this is another variable that we have to think about as we serve folks, and how to do this in a loving way. We also have many that are self-pay and uninsured, or who have Medicare only with no supplement, and therefore every visit is going to have a 20% fee attached to it. It could also be that there will be many mental health professionals who do not see Medicaid patients. And we have different groups of patients. So when you think of primary care, you have a variety of folks within that come through the doors. Some will be seeking mental health care. They actually are interested and are looking for it and asking for it. But you have others that where the need is evident. Say they fill out a depression screen or an anxiety screen, and we see that the need is evident, but they're really not seeking care though. So this is a kind of a different context for patient care. Then you have some where, again, the need is evident, but they're really ambivalent about care. Um, they sort of kind of have mixed feelings about it. They're maybe open to talking today, but they when it comes to whether or not to schedule a visit or to come back, they're may not be likely to. And so we also have this, kind of disproportionate number of patients who are not even receiving treatment. So 46% of U.S. adults with mental illness receive treatment. So less than 50% with mental illness in 2020 were receiving treatment. So expanding this out even more, the referral system. So when you refer a patient for a scheduled behavioral health visit, you have multiple things to consider, such as how long will it be till the next visit is available. So if you refer them, how long will it be for the referral department to call them, and then how long until they can get in and be seen. And so we find low attendance for outpatient referrals, and so there will be some who will never even actually get scheduled, and then an even lesser rate for those that actually successfully connect for the visit. So you have to ask yourself, if I refer, will they actually schedule, and will they actually come for their scheduled appointment or be a no-show? And so the referral system is part of the problem and equation when we look at accessibility, and then how we frame that solution. So we have the time to gain access, which I've mentioned. There can be delays, there can be cancellations, or just a lack of access to providers. But then there are the resources to gain access, such as, do they have transportation to get to the appointment? Does this provider offer telehealth if they don't? Do they have childcare to be able to go to the appointment? Do they have insurance? And if they do, but the provider doesn't accept their insurance but offers a super bill, which is what you see often, they'll say, we can provide you a super bill that you can give to your insurance. Can the person do that? But then you have provider factors. Does the provider have limitations on what ages they'll see? Are there restrictions on the type of problems that they will see? What about day and evening hours for patients who have limitations there? And then there are payer factors, such as managed care issues. And then there's also a culture within our profession. So whenever I looked at this one website, I was looking for a referral for a patient that I needed to get a new provider in Nashville, and I'm trying to get this quote without my face over it, y'all. But the bottom line here is that the website said, our most popular question is insurance, and it says we do not directly contract with health insurance at this time, and it says which is fairly common practice in our field. So it's very common for mental health professionals in private practice to not accept insurance, and so people have to pay self-pay, sometimes well over $100 per session, and so that bears the question, do all have access to the same quality of care? So the other thing for us to think about is the patient context friendly to treatment seeking? Things such as stigma, or have they had prior negative experiences with mental health providers? And do they understand how to navigate the system? Things such as health literacy. Do they understand the difference between a psychiatrist versus a psychologist? Do they know what these different titles mean? LCP, LPC, LCSW, LMFT. Do they understand different levels of care and which is most appropriate to their needs? And what ends up happening is that primary care has been described as the de facto mental health system. And so what we see is that most primary care patients with mental health concerns, they are identified or initially treated in primary care rather than the specialty mental health system. So even if we don't have a mental health provider embedded in that system, they end up getting treated there first anyways. So we've seen that the percentage of visits to PCPs that include a psychiatric prescription has increased significantly faster than the corresponding percentage of visits to psychiatrists. So PCPs are prescribing these medications. And it also is true for children and adolescents. These children and teens will make their way through pediatric offices. So why then would we do integrated care? So patients with mental health diagnoses, they do frequent primary care, and there tends to be an increased healthcare utilization, which has implications for healthcare costs, and also health outcomes. And we see that within primary care visits, there will often be psychosocial factors evident during those visits. And many times PCPs don't feel comfortable or confident addressing psychosocial concerns. So who are the patients? So we may see psychological problems that present in medical settings. Most common being depression and anxiety, and a ton of grief, especially since the pandemic. A lot of trauma in many communities, and also pediatric behavior problems. We also see problems that include both physical and psychological components, including substance and alcohol use concerns, and also tobacco use. So we also see primary medical disorders with biopsychosocial correlates. So things like diabetes, HIV, COPD, a new cancer diagnosis, and these are all areas where a behavioral health clinician can be helpful. There are also factors related to acute and chronic illness that account for a substantial proportion of treatment failure and increased medical costs. So high ER utilization, treatment non-adherence, cases where there's no identifiable medical etiology, illness anxiety, somatization, and social determinants of health. All of these things are very evident in primary care. So the implications are that patients with behavioral health needs still frequent primary care daily, even if BHCs are not there. And in non-integrated settings, PCPs rely on prescriptions and the referral system as their only tools. And it becomes clear that a behavioral health clinician has an expanded scope of practice in primary care and must learn to be helpful for a range of presenting concerns with biopsychosocial correlates. And it also becomes clear that in order to not replicate the same problems of the specialty mental health system, we'll have to modify service delivery to promote accessibility at the time of need. So expanding the frame, premature treatment termination is another variable. So approximately 1 out of 5, give or take based on setting, will terminate treatment early, and over 70% of those occur after the first or second visits. So this is particularly in context working with non-treatment seeking groups, and highest rate of dropout in the general medical sector. So this also informs how we deliver services. So the modal number is 1, with a mean of 5. So the motto that I go by is treat every visit as if it could be your last. You hope for 3 to 4 visits, but you don't plan on it. And so you want to make each visit count. And this really does have a different mindset for your consultation and does inform how you approach that first visit, which is very different than we are trained for traditional settings. So framing the solution, we are going to be expanding stepped care by adding the primary care level to the mental health system. So patients are first offered the least restrictive treatment that is still likely to provide some benefit. And then they are stepped up in treatment intensity if sufficient health gain is not achieved. So we'll be adapting how that level of care function as not to recreate some of the same problems. So population health is the vision. And the aim here is to enhance the care of a significant proportion of the population through brief, low-intensity intervention and consultation. Alternatively, specialty settings provide high-intensity services for a comparatively small percentage of the population. So the motto here is a little for a lot at the time of need, rather than a lot for a few. So what is integrated care? It is a term with many meanings. It is a process and product of medical and mental health professionals working collaboratively and coherently toward optimizing patient health through biopsychosocial modes of prevention and intervention. It's not really defined by one type of service or setting. It's most commonly in primary care. The function of integration remains constant, though the system itself may actually take many forms. So behavioral health defined, it's much more broad. It includes mental health, it includes substance use concerns, health behaviors, life stressors and crises, stress-related physical symptoms, ineffective patterns of healthcare utilization. So when we speak of behavioral health, think of it much more broadly than mental health, so to speak. This is a much wider net. So we'll classify systems based on their level of integration. Low integration is whenever there's coordinated care, but behavioral health services are separate from primary care, but they're trying to work together in some coordinated way. A midpoint integration would be, let's say, co-located in the same space, but they still have separate treatment plans, separate billing, separate scheduling systems. Maybe they're not able to look at each other's notes and documentation. And high integration is when things are fully integrated, where there's a shared clinic space, shared medical record, shared front desk, sharing exam rooms. So when you look at whether or not a system is doing integrated care, we would classify those based on their level of integration. So the essentials of integrated care, so think of working together using one treatment plan, whether in the same location or not. And the level of integration can be measured using different measurements, which is a talk for another day, but there are measures for this. The goals, some parallel traditional mental health, but some broaden the scope of practice. So some of the aims are improved recognition of behavioral health needs in medical settings, improved collaborative care and management of patients with psychosocial issues in primary care, and increased availability of an internal resource for PCPs to help address those concerns, and then to provide rapid feedback to the provider without referring to a specialty mental health clinic. Prevention of more serious behavioral and physical health problems through early recognition and intervention, which is a great opportunity. And to triage when appropriate to more intensive specialty mental health care by the BHC. So same-day access is a goal wherever possible. So when a medical professional identifies the patient or when a staff member does. The BHC can be invited into the visit for a brief assessment and intervention. And this can provide seamless care and coherently address all presenting problems, not compartmentalizing physical and mental concerns. And this would remove the delay time for the referral and remove stigma associated with seeking mental health services at a mental health facility. So if you can pop right into their exam room, nobody knows they were seen for a mental health visit because they're at a primary care clinic. So when integration is done well, you bypass inconvenience of making another appointment, resulting in more completed referrals. More patients receive services at the time of need, and BHC's time to address those concerns is less costly than the PCP's time. And it also frees up the PCP to move on and see other patients. Potential to improve the physical health of a patient when biopsychosocial correlates are addressed. So to meet those expanded goals, we do need a new model of service delivery. There's not a one-size-fits-all model. Two major models have emerged, the PCBH model and the collaborative care model. And then there are other population-specific models, such as SBIRT and MAT. Both of these focus on substance use disorders. Now, when you look at horizontal versus vertical integration, really what this is referring to is with vertical integration, there's a slice of the population that integrated care model is trying to target. So for example, the collaborative care model is often associated with depression, and so it's very much focused on that slice of the patient population. With MAT, it's opioid use disorders, and so the integration is focused on that slice of the population, whereas PCBH is much more broad and encompasses a range of patients. So it's referred to as horizontal integration. We'll be focusing on PCBH, and really the focus is going to be on the how of doing this. So how do we define PCBH? The PCH model is a team-based primary care approach to managing behavioral health problems and biopsychosocially influenced health conditions. The model's main goal is to enhance the primary care team's ability to manage and treat such problems, conditions, with resulting improvements in primary care services for the entire clinic population. The model incorporates into the team a BHC, sometimes referred to as a behavioral health clinician or consultant, to extend and support the primary care provider and the team. The BHC works as a generalist and an educator who provides high volume services that are accessible, team-based, and a routine part of primary care. Specifically, the BHC assists in the care of patients of any age and with any condition, so a generalist, like a PCP, and strives to intervene with all patients on the day they are referred, so accessible. Shares clinic space and resources and assists in the team in various ways, team-based. Engages with a large percentage of the clinic population, high volume, helps improve the team's biopsychosocial assessment and intervention skills and processes, so an educator. So here we're looking to improve the team's ability to provide that care. So even in the absence of the BHC, if they're with a different patient, the team is better able to meet the needs of the population, and is a routine part of biopsychosocial care. To accomplish those goals, BHCs use focused visits. So you see the time is a little bit different, 15 to 30-minute appointments, which is different than the traditional 45 to 60-minute psychotherapy hour. Follow-up is based on a consultant approach in which patients are followed by the BHC and the PCP until functioning or symptoms begin improving. At that point, the PCP resumes sole oversight of care, but re-engages the BHC at any time as needed. And patients that are not improving are referred to a higher intensity of care, though if that's not possible, the BHC may continue to assist until improvements are noted. The consultant approach also aims to improve the PCP's biopsychosocial management of health conditions in general. So this image compares and contrasts the two different levels of care, and for purposes of time, I'll invite you to pause the tape and read through this if it interests you. So consultant versus a therapist. Therapist assumed the role of mental health care provider and plans to follow the patient until they improve to the point of remission. Consultant does not follow to remission. The consultant is not the main provider of care. The PCP is the main provider of care. The consultant's main role is to help the PCP by following patients along with the PCP until they are starting to improve and have a clear plan for continued improvement, at which point the role is complete. If the patient's condition worsens or new problems arise, the consultant may be re-engaged in care. This model helps ensure visit slots are always open for new patients. Being intentional with this approach helps avoid filling the BHC schedule with the same small group of patients repeatedly, which would replicate the more traditional model and the accessibility problem. So within this model, behavioral health clinicians will have a mixed schedule. So there will be a mix between scheduled slots and same-day slots, ideally a smaller number of scheduled slots to make room for plenty of what we call warm handoffs for same-day referrals from PCPs. And patients can be worked in at any time during the day, and the same-day slots can allow for flexibility and adaptation to the needs of the day. As we think about the schedule, one thing to note is that we want there to be variability. So on a given day, there may be some visits that are shorter and more focused, and then there may be some that are longer. And this will be similar to a PCP. Some they may be in and out briefly, and then others may be more complex and take longer. So the main thing we want to do is make sure that there is variability. We don't want all visits to be 45 minutes long, though some might be. Some might be 40 minutes, some might be 35, some might be 15, some might be 10, some might be 20. The idea is to have variability like a PCP would. If a clinician finds themselves falling into a rhythm of everything's 45 minutes, then you know you've sort of drifted back into a more traditional approach. And so as we think through this model, we want to aim for 15 to 30 minutes. However, it's not rigid, and some might go a little bit longer, but some ideally will go a little bit less. But by the end of the day, hopefully it'll all pan out into being a fairly balanced approach. So universally, appointments are described to be 30 minutes. And not all will actually last 30 minutes because many are not pre-planned and they're worked in. Sometimes the patient only has 5 minutes to give you, and or maybe they've only got 15, or maybe they're really tired, they've been there for a while. Any number of things. Similar to PCPs, the amount of time spent fluctuates based on various factors. So key adaptations for mental health professionals. The work pace in primary care is much faster than behavioral health settings. We must have the ability to adapt and adopt a brisk work pace to be able to conduct brief and focused sessions and continue to see many patients in a practice day. So flexibility is required. We have unexpected changes in our workflow, PCPs or CMAs knocking on our door, getting Teams messages coming in saying, hey, can you see a patient? Competing needs such as a scheduled visits here, but I've got a handoff. And so the need is to be able to think calmly, move quickly, to adapt. And so one way to look at this is being like a duck. So you stay still up top, but your little feet are pattering underwater. And so that motto has helped me over the years to, to be able to maintain my composure, especially with the PCPs who are a customer of mine and I'm there to serve. During those duck moments, my experience has been that sometimes you will be asked to do a handoff at a time where maybe you have a ton going on. And so the challenge is, how do you say yes more often than not? And then to find your adaptation. And so typically what I will do is ask things like, has the doctor already seen the patient? And do they have to get labs? Is there anything that can buy me some time to get there? So ideally, if the CMA tells me early and I've got some time to get there, like maybe there are 2 patients ahead of this person, then it lets me know, okay, I've got to make some changes so that I can get there, but I've got 20 or so minutes to get there. And so the main thing is, even if you're busy, not to be quick to say no. Be flexible and do your very best to say yes more often than not. Because if we say no too often, then PCPs will eventually stop asking and they'll just do the referral system. So handoffs from them, a warm handoff is when it actually happens in the moment. Ideally when the PCP walks you into the room and introduces you and you borrow their rapport. A more cold handoff would be if they move on and you just walk in and introduce yourself to the person. Or even more cold would be if they leave the clinic and you call them. And so it's still a handoff, but it's definitely not a warm handoff, so to speak. If they get referred same day and then go into the referral system, I mean, it's a referral, but it's definitely not a handoff, even though it was made that day. Handoffs essentially same day. So these moments can be a little bit wild, chaotic, and so a saying that's really helped me over time is, "Blessed are the flexible, for they may not be bent out of shape." And so, being the duck, being flexible, finding your adaptation, and then finding meaning in it. I find that same day access has meaning now for me, because I know that there's a very good chance that once those folks are out the door, I may not have a successful referral. And so it's worth it to me to embrace the flow of all of that. And so much of this will lie in your mindset towards it. Key adaptations, we need to be very effective communicators and have the ability to consult with medical team members and be able to do curbside consults with PCPs, to be able to collect the referral question, to be able to document efficiently, to write notes that PCPs will read and that will be useful to them, to be able to do a consultation and come back and close the loop with the PCP. Other strategies to promote accessibility include being visible and being present. So put yourself out in the pods with the medical providers. Otherwise, if we hide and kind of nest in our rooms, we're sort of out of sight, out of mind. But if we're out and visible, they may come out of a room and be like, "Oh, hey, I think you could be helpful with this patient. So my encouragement would be to resist nesting and hiding back in your office taking notes, but to be out in the pods with the providers and with the nurses and with the CMAs, so that you can be visible with the team and be accessible to the team. Because we don't want to replicate the same problems of the specialty mental health system, we want to make sure that we set expectations up with the patient early on. Otherwise, they will come in with preconceived notions of who we are and what we do, perhaps based on prior experiences with therapy or with what they've seen on television shows. And so we want to make it very clear to them what they can expect from a behavioral health consultation. By doing this, this helps to create a frame for what we're doing and what this visit will look like. And this helps to set us up downstream to make sure that we maintain access, because if we don't make it clear to the patient what to expect, we may fall into those same rhythms of, okay, I'll see you in 1 week and 45 minutes each time. And so this starts at the level of how the PCP introduces you. Do they refer to you as a counselor or a therapist, or that you'll be doing therapy with them? That sets up expectations. If they refer to you as a consultant, or that you'll be doing a consultation for them to see if you can be helpful, and that will make a difference in how they perceive this encounter. And then having a very good intro for yourself, or how you introduce services to your patients. This can make a huge difference for the trajectory of the encounter and the patient's expectations thereafter. So some things that I always make clear is that I do have a consultant role and that today is a consultation. I make it clear that we'll have a 30-minute visit, and that some patients see me just once and feel like they got what they needed and will just let me know if they need me. And other patients I may see for a follow-up visit. And that at the end of each visit, we'll decide whether we need another visit. And I explain to them that that's the primary care level of care, and that if a patient needs a more traditional model, we can always set them up with a referral. Then at the end of the visit, I can come back to my intro and frame this as sort of single session therapy. Okay, so at the beginning of the visit, we discuss this, and then we begin to discuss a plan for aftercare. Do they prefer to do just a same day consult, or do they feel like they need a second visit? And I could say a whole lot more about this, but the bottom line is that if you're doing this work, really just shaping your intro over time can be very fruitful. I've been shaping mine for about 6 years now. So in order to promote accessibility, we want to use the time that we have well. So during a consultation, the ability to develop rapport quickly, to learn focused interviewing, to ask questions that elicit the information that you most need, and to be able to assess the problem rapidly and to gather enough information to be helpful for the day, to come up with a problem formation and a focused intervention. And then having that mindset in place of treating each visit as if it could be your last, and to conceptualize episodes of care. Because in primary care, nothing really is brief about primary care. You are accessible over the lifespan, but there are episodes of care. It's not an ongoing, every week for, an unending amount of time. That's not how primary care tends to work. So, but people may come to see you in episodes of care. So this is a problem formation kind of stem that we use. So this can help to orient you to what you're working on. So for example, patient presents with blank in the context of blank related to blank who would benefit from blank. If you ask yourself this question after a consultation or towards the end of a consultation, it really can help you begin to think about your focused intervention and begin to be intentional with, all right, what are we doing with this consultation? So an example of this would be patient presents with depressed mood in the context of grief related to the loss of her son 1 year ago, who would benefit from learning experiential acceptance skills and from behavioral activation and from whatever it is that you come up with. I just wanted to give you an example of how that might work. And so this helps you to really have a very focused problem formation, and by running your consultation through this STEM, it can really help you to have a very focused consultation. So dosing and titrating care also helps to maintain your access. So we want to be able to assess the problem and think through an initial recommended dose or intensity of care. So we want to consider the patient's preferences. What do they prefer for their care? How intense is the problem? Are they early in the process, or is this chronic and unrelenting? What is their level of engagement and their readiness for treatment? What barriers to treatment need to be accounted for? And we want to resist the instinct to put all patients on the same dosing schedule. So an example would be no variability, all patients just automatically follow up in 1 week. We want to take into consideration all these other variables and then decide, okay, what would be an initial dose of care that I would recommend for this person. So for example, 2 to 3 visits starting out with every 2 weeks, or maybe for a more intense situation, plan for 4 to 6 visits, starting out with weekly, then moving to every 2 weeks, which is where we get into titrating care. We also want to resist the reflex to refer out immediately. Think like a PCP. Don't assume they'll go to a referral, and try to do something that day. And then schedule your follow-up, and if they're not improving at this level of care, then you can refer them. There may also be some cases where it's pretty clear to you that they could benefit from a traditional model. Again, just be thinking about their level of engagement, their readiness for engagement, their barriers, all those things. Just think it through, and try not to have a reflexive response. So mindfully choose and plan care is what we're aiming for here. So titration of care is how you administer care over time. And so you assess response to treatment at each follow-up appointment, and at each visit decide whether another follow-up appointment is needed based on the impact of the intervention, symptom severity, level of engagement, and the patient's preferences. So resist assuming a follow-up visit is always needed and that your patient prefers that. It's okay to talk about it and to ask them what they prefer. So choice making, mindfully recommend follow-up plans based on response to treatment and patient preference, while also remaining aware of your access to the community. So why do this? To maintain our access while also providing some care to many, and referring appropriately if low-intensity interventions are not effective for a patient. So keep in mind, episodes of care, even if we do not plan a follow-up, we want to make it very easy to come back for a new episode of care at any time. So when to refer, there's variable guidance on this. Severe, one recommendation is severe and persistent mental illness, psychotic symptoms, treatment-resistant depression, severe substance abuse, poorly functioning patients with substance use disorders. When it is unclear if a patient would benefit, consider their preferences, and work with the BHC initially and defer the decision about longer-term interventions until the end of 4 to 6 sessions. So that's one recommendation. Another is to refer to specialty mental health only when the patient needs psychiatric care, emergency psychiatric care, fails to improve in response to care from the PCP and BHC. The patient specifically requests specialty mental health care, needs specialty mental health assistance as requested by the PCP. So patients are not screened out of BHC visits, and the goal is to treat patients first in primary care, only referring to specialty care in the circumstances noted above after consultation with the BHC. We should not presume the patients always need specialty care. This approach helps ensure that the specialty care system is reserved for the patients who need it most. Lastly, a key concept, in most cases, the BHC provides first-line intervention in primary care, referring only if symptoms or functioning do not improve with PCBH intervention, or when a higher level of care is clearly indicated, such as elevated suicide risk or need for psychiatric care. So we want to describe these referrals as an addition to their care team. So we want to be cautious not to present as they can't be seen again, or that they're so severe that they have to be sent somewhere else. And so by framing it in this way, it doesn't mean that we are encouraging to have 2 therapists or 2 cooks in the kitchen. That's not the point. The guiding principles here are to maintain role clarity as a BHC in a situation like this, to have communication with outside providers as needed, and to make it a priority to not interfere with their treatment plan with the external provider in any way. Once care is established, the BHC can step away and remain accessible PRN, or maybe check in with them when they're in clinic for a medical visit. Most often I'll check in to see, are they still going to see that provider, to check in on engagement, and then remain a resource at any point in the patient's primary care trajectory. So we want to describe what they'll receive in specialty care and the evidence for the approach, and be mindful they may or may not be interested, or they may not go to that referral. Continuity visits in cases like this may be required, and in which case I may see somebody monthly for a continuity visit. The main thing here is that we want to try not to make a habit of this, because if you get too many continuity patients that really need more long-term care, but you've had a difficult time getting them established with care, your schedule can quickly fill up, which then restricts access for all of the same-day visits. So we just need to be mindful. Remember, nothing about primary care is brief, so think focused, think team-based care, think consultation. Keep in mind that brief does not have to mean superficial or lacking in precision, scope, depth, or potency. I would challenge you to grow and to be open to making these focused visits count. Finding the golden thread is sort of my way of tracking process and listening with depth. And the framing that I have for this is, if a person was to make one change that would make a huge difference in their trajectory, what might that be? And that's a longer discussion, but this is something that I tend to think about towards the end of the visit, and it helps really find that golden thread that I'm looking for, and then I can use that to inform my intervention for the day. Track and gravitate. So this is like listening for values is one way to think about this, and to gravitate towards the heart of the matter. Um, but another way to think about it is like a dental exam, which I think I might have on another slide. But you're sort of poking and probing and trying to look for the wince, so to speak. And that's where you begin to perhaps find the heart of the problem. You may find 3 different teeth where you have a wince, and then you have to decide which one are we going to work on today, which one is most potent, perhaps. But as you listen to people, you can sort of track and gravitate towards the heart of the matter, like a dental exam. There it is. So to maintain access, a point of encouragement is to remain mindful and aware of what we call practice drift. And that's where a person starts to sort of drift back towards their old habits of a more specialty mental health pattern. And then also role confusion. And so as you learn about integrated care, beginning to really internalize the consultant versus therapist model, and being able to really understand your role well can make a huge difference. And remain aware of your philosophy of care and sort of your guiding mindset and principles for how you conceptualize your role. How aware you are of team-based care versus sort of looking at yourself as the care provider. So there's really a lot that you want to be aware of in order to be effective in this environment. So keeping access and team-based care at the very front of your awareness, like a compass. For time purposes, I will have to be brief with this topic, but it's worth noting that as a workforce, really we don't have integrated care offered widely yet. It's growing, but it's still not widespread. And many of the integrated clinics are not located in the highest need communities. So I thought it was important to note that. And another essential variable is the need to find Christian providers who are mission-minded behavioral health clinicians. And so here, finding those who are a good fit for this type of environment, who don't mind the knocks on the doors, who don't mind being flexible to work in same day handoffs, who enjoy working as part of team-based care, who believe in the vision, though also love God and love others, those who are willing to pray with our patients, and those who have a heart for the underserved, those who are willing to work in the communities that we serve. As we think about expanding this work, and as it continues to grow and more clinics offer integrated care, we do need to think about training. Keep in mind that most mental health professionals are not trained for primary care specialization. And so if we bring people into this environment with no training, we sort of set them up a little bit for role confusion, and they may have a lot of specialty mental health behaviors as opposed to primary care behavioral health behaviors. And so we want to be mindful of that, that there will be a need for training, and also supervision and mentoring, and ability to manage clinic flow and a new role. And so we also have a lot of different professions, so psychologists, social workers, professional counselors, marriage and family therapists. So a lot of different training. So anybody who is beginning this work, it's very, very much a consideration of how we will train these folks. As you consider where to learn more, a great resource is the Collaborative Family Healthcare Association. It's a professional kind of community for PCBH and integrated care. There's an APA journal, Family Systems and Health. There's a certificate course through UMass Medical School, and there's also live training events through Cherokee Health Systems. Those have been paused during the pandemic. There's also the Interprofessional Primary Care Institute that does a live virtual event each year. And also Christ Community Health Services, part of my role is to begin to offer training and develop training over time. And so we will be offering live events, but also working towards an on-demand course. And one note to make there is that some of these trainings can be costly. So one of the missions that we have at Christ Community is to try to make training affordable, especially for early career professionals. Here's my contact information if any of you would like to reach out to me. And also here's a QR code that links to a Google form if any of you are interested in training opportunities to learn more about primary care behavioral health. You can provide your contact information, and next time we have an event, I can always send you the flyer. I want to say thank you for your time and for your attention. I really do appreciate your presence and for your taking the time to watch this video and to engage with this material. Thanks a lot.